Oncology for the Inquisitive Mind, where we have finished our 2026 ASCO extravaganza. And I'm joined here, as always, with my co-host, Michael. But before I ask him how he is, I'll reverse things just slightly today. Today, Michael, I'm going to talk about what we're discussing, which is really an orphan set of cancers or biliary tract cancers. And Michael's going to start with the adjuvant treatment, and I'm going to jump into the stones or the hubris, as you might say, when, we're talking about topaz, but they could have named it zirconium or citrine or sapphire or aquamarine, but they went with topaz. Maroon stone, lots of different interesting stones to talk about. But Michael, good to see you. It's the afternoon. How are you?
I'm good, Josh. I'm just glad they didn't call topaz goldstone, given that we're talking about biliary tract cancer.
That would have actually been maybe quite appropriate.
Very appropriate. Not as sexy as topaz, I think.
No. But Michael, before we get to topaz, let's talk about BILCAP, your study.
Yeah. So getting right into it, I guess the background of this is, as Josh said, that the biliary tract group of cancers are one of those cancers that I feel like no one enjoys treating these. I think it's fair to say, because the anatomically they're very difficult and there are high rates of complications from obstruction and metastatic spread, local metastatic spread, and they present a therapeutic challenge because there is a paucity of options. Furthermore, the incidence of biliary tract cancer is increasing. And, we joked about calling topaz gallstone. There is a theory that this is due to the increasing incidence of gallstone disease, that you have higher rates of inflammation, whether that's your cholecystitis or your choledocholithiasis or all of the other lithiases family of products. But and they're causing greater amounts of chronic inflammation, probably associated with a metabolic component, and you have an increase in the disease that way. Now, much like all hepatobiliary cancers, potentially curable resection is feasible in a minority of patients, about 20%. And the post-operative median overall survival, particularly in patients with positive lymph nodes or positive resection margins, is poor. If you don't have any of those things, it's about 18 to 30 months, which, when you compare it to breast cancer, melanoma, colorectal cancer, it's pretty poor. And it is worse if you have adverse surgical outcomes. There was a randomized trial by Ibata et al. In 2018, which demonstrated no benefit of adjuvant gemcitabine. So as far back as 2018, probably earlier, let's be honest, but as far back as 2018, people were looking to see if they could improve that 18 to 30-month median overall survival. Gemcitabine was one of the first to come up to the plate, and it didn't really do well, with a hazard ratio of 1.01 and a p-value of 0.97, so about as non-significant as you could get. There was also a phase 3 trial of adjuvant GemOx, gemcitabine and oxaliplatin, which is not a regimen that we commonly use, but it was also not statistically significant. There was a large numerical benefit with the GemOx group having a median overall survival of 50.8 months versus 50.8 months in the surveillance group, I should say, versus 75 months in the GemOx group. So that's 25 months. It's more than a year. But it did not reach statistical significance, and I'm not going to go into the reasons why. But we come to
Why not, Michael?
Well, no, I'm not going to do that, Josh. I just said.
I just wanted to see.
It's almost like you're not listening. I suspect there were wide confidence intervals.
Maybe I'm actually listening for once. That's the difference.
Yeah, and he uses his power for evil rather than niceness. But today we're going to talk about the winner of this fight club, as it were, which is BILCAP. So this is the consort diagram for BILCAP, which is pretty standard stuff. So it is. There were 447 patients, and it is a study of adjuvant CAPE versus observation. Now, patients will randomize 1-to-1 into the two groups, And the inclusion criteria were histologically confirmed cholangiocarcinoma, muscle-invasive gallbladder cancer, and the cholangiocarcinoma could be intrahepatic or extrahepatic. They had to have a macroscopically complete resection with curative intent, so it couldn't be a palliative resection, and they had to have an ECOG performance status of less than 2. There was a major protocol amendment during recruitment, which extended the start date of chemotherapy first from 8 to 12 weeks and then to 16 weeks after surgery, hinting that these patients needed a long time to recover. But it also is interesting because, spoiler alert, there will be a benefit to this treatment, and that is despite extending the window for adjuvant therapy. During the time of recruitment, SPAC3 came out, which demonstrated a benefit, albeit after a multiple regression analysis, because they didn't quite get there initially, of adjuvant capecitabine over observation in resected periampullary cancer, which is further down the biliary tract. And so the authors of BILCAP expanded the field, as it were, to allow for patients with extrahepatic cholangiocarcinoma to be enrolled. The primary outcome was overall survival, and the secondary outcome was a per protocol analysis of overall survival through the population, and recurrence-free survival, toxicity, health economics, and quality of life. We won't talk about all of those today, but we will talk about some of them. So just so that you know as well, the total number of patients enrolled was 447, but the per protocol population was 430 because 17 patients were excluded. 7 patients were found to be ineligible after randomization, so they snuck through the net, as it were. 9 patients did not receive any dose of capecitabine, and 1 patient was both ineligible and didn't receive any treatment. So for the per protocol analysis, those 17 patients were excluded. The median follow-up for all patients was 60 months. In terms of the demographic notes, it was fairly even spread between intrahepatic cholangio, hilar cholangio, muscle-invasive gallbladder cancer, and lower CBD cholangio. If you average them out, they'd be about a quarter each. 3/4 of patients had an R0 resection at the time of surgery. 48% of patients in the CAPE group and 46% in the observation group had node-positive disease, and the majority of patients had a histopathological staging of stage 2. So, in the intention to treat analysis, the median overall survival was 51 months compared to 36.4 months, and unlike the previous studies where you had this numerical benefit but it didn't reach statistical significance, this was statistically significant, again, after adjustment for prognostic and minimization factors, with a p-value of 0.01 and a hazard ratio of 0.71. So with a little bit of statistical fettling, this is significant. But again, there is that nice separation of the curves, as you can see. In the per protocol analysis, as you can see on the slide here, the median overall survival was 53 months compared to 36 months, so very similar with those 17 patients excluded, so probably not a huge amount of difference there. And again, that was statistically significant. The RFS was higher in the capecitabine group, 24 compared to 17 months, but I thought that I'd talk about a couple of statistical interests here, because as you can see, for those of you watching on YouTube, the relative risk seems to vary, where the curves are not necessarily even, and I've bored Josh and sent him away. The curves are not necessarily even, and so the relative difference in risk varied, and they had to use Cox models with time-varying effects. And basically what this is it broke down into RFS in the first 24 months and then after 24 months. And what was interesting here is that the adjusted RFS in the first 24 months had a hazard ratio of 0.75, which was statistically significant. That's before 24 months. After 24 months, there was no difference. There was a hazard ratio of 1.28 with a p-value of 0.21. So I thought that was interesting. The numbers were similar in the per protocol analysis with those 17 patients excluded. And I did want to, here is the forest plot, which shows that, yes, most, if you were talking about this in a major conference, you'd probably say that capecitabine was superior across most pre-specified subgroups. But you can see that there are a lot of subgroups with small numbers that did cross the line of equivalence. So, in practice, Josh, we just basically give capecitabine anyway.
Is that the summary?
That's pretty much the summary. I did want to make a note on a very quick study, which is the GAIN study, because when we're talking about sort of management of early biliary tract cancer, I think we mentioned this in our post ASCO or ESMO, one of those ones when James McCracken came on, because this is a study of perioperative cis-gem, 3 cycles before, 3 cycles after, versus immediate surgery followed by adjuvant chemotherapy, which was clinician's choice, but you would assume that it is mostly going to be capecitabine. The reason this is not the main big ticket item today is it was a small study, only 68 patients, but there was a very high rate of completion for the neoadjuvant chemotherapy, greater than 90%, compared with less than 50% of patients who completed the adjuvant therapy. And the median overall survival in the GAIN study was 27 compared to 14 months. So that standard of care group underperformed a bit, small numbers as well, but there was a hazard ratio of 0.46. So this is sort of a flag whether biliary tract cancer is going to go the way of gastric and GOJ cancer, with perioperative FLOT. So that is something that may be coming to a hepatobiliary centre near you, but it's still probably a bit too early for prime time.
Time will tell. Interesting study. I think the summary is give adjuvant capecitabine because it works, and after 2 years, there's no real difference.
Yes, exactly. You shouldn't be. I cannot remember exactly how long they gave the capecitabine for, but I would imagine that you wouldn't be still getting capecitabine after 2 years.
I assume not.
No.
We can look it up, but there's a protocol, and I'm assuming it's a couple of months of adjuvant therapy.
Yeah, I would assume it's around 6 months. Neither of us treat hepatobiliary cancer, in case you were wondering. But Josh, we have gone the early stage. We've talked about gallstone disease. Now why don't we talk about the other precious stone in this episode, which is not you.
Me.
I knew it. I knew you were going to say that. No, let's talk about Topaz 1.
Yeah, sounds good, Michael. So I started these slides a month ago, maybe a month and a half ago, when we were talking about doing this episode. And so I was like, I've got to look over it again. And I sort of did. So let's talk about Topaz 1, which was a foundational change in the way we treat biliary tract cancers. So that's the update. But no, so it's a heterogeneous group, as Michael has already very kindly gone through. But I'm going to say it a second time in case you weren't listening. And if you were, you should definitely like and subscribe. So biliary tract cancers include intra and extrahepatic cholangios, gallbladder cancers, and pulmonary cancers. They're typically diagnosed in an advanced stage because they're asymptomatic until late stage, which means prognosis is poor. Despite many, many trials, gemcitabine-cisplatin has remained the standard of care for a decade for this cohort of patients. And the trial for this versus gemcitabine alone, the overall survival being 11.6 versus 8 months, and not seismically changing, and progression-free survival was about 2 months more, but everything was shy of a year. That trial was from 2010. The median overall survival at the moment stands at 11.7 months, and the 24-month survival is 15%, so it is pretty poor. The hypothesis with biliary tract cancers, like what Michael already alluded to, is that they actually exhibit immunogenic features, including expression of immune checkpoint molecules like PD-L1 and cytokine T lymphocyte-associated protein 4 tumor microenvironment. So the question is, if you give immunotherapy, will we change this and improve the outcome? Hold tight and you'll find out soon enough. And of course, this drug was by AstraZeneca, so it's Durvalumab we're talking about today. There was a phase 2 study which showed gemcitabine plus cisplatin and durvalumab had an objective response rate of about 72% and a median overall survival of about 20 months in a non-randomized single center trial. This trial was a phase 3, which is, I think, the first thing to talk about. It's phase 3, which is good. I will share my screen to make sure that you can all see what you need to see. So, Michael, this is the TOPAZ-1 design, and it was really locally advanced disease. They were good performance status. They were randomized 1-to-1 to either durvalumab plus gemcitabine and cisplatin up to 8 cycles versus placebo plus gemcitabine and cisplatin. So the difference was the durvalumab arm. They had up to 8 cycles and they continued either placebo or immunotherapy until disease progression. Primary endpoint for this was overall survival, and the secondary endpoints was everything else we know and love: progression-free survival, objective response rate, duration of response, safety, tolerability, biomarkers, and there was the PK stuff as well. Moving along, let's go straight to the results. But in this case, I'm going to do something different. We're going to do take-home messages. It's literally an ASCO episode. Michael, you're muted. Anyway, TOPAZ-1 now represents...
I was going to say old habits die hard. That's all I was going to say.
Yeah, that is also an old habit, staying muted, right? So the take-home message for TOPAZ-1 is that it is now the new standard of care for advanced biliary tract cancers. The 3-year overall survival data showed that it was 14.6% versus 6.9%, and overall survival of 12.9 versus 11.3 months, with a hazard ratio that was statistically significant at 0.76. Progression-free survival was also better by about 2 months, with a hazard ratio of 0.75, and overall tolerability was quite good. Discontinuation rate for the intervention arm was about 13%. When we look at the Kaplan-Meier curves, so overall survival, and I will talk a little bit more about this, this is also really what's interesting. You can see that there is that division of the curves as you move further on. And I think follow-up time was 3 years, give or take. And it's sort of plateaued as well with a lot of trials, which is sort of about that 10 to 20%. And even the median progression-free survival here, as you can see, is also about 10% as well. So overall, the trial did demonstrate statistical significance. And the interesting thing moving on from that is those that achieved advanced disease control, about 82.6%. The 36-month overall survival rate was actually higher in the durvalumab group, even more. So it was about 17% versus 7.6%. So like many of these studies, what we find is that if you responded well initially, you're likely to continue to respond moving forward. I've just got a slide here of response rates, and you can see how many people sort of had an ongoing response after 12 months, and that's about 26% versus 15%. So you're adding almost 10% to benefit to 12 months or more if you're giving immunotherapy with this cohort of patients. So Michael, I've already given the nuts and bolts of this. Toxicity was pretty similar between the arms when it comes to chemo versus chemo plus immunotherapy, and treatment-related adverse events that led to death were 2 versus 1. You know, a lot of these things, I don't actually think it was durvalumab related. I think it's just when you're treating a really difficult set of diseases.
Yeah, I mean, it's for anyone who's done trials, both Josh and I have done them. It's really hard to pinpoint a cause because these are difficult diseases, and you know, really it could be anything that knocks these patients off when we do have these really bad toxicities.
That's it. And just to contextualize it, you know, yes, I know the numbers are somewhat like that, those old small cell trials with the Empower data, but it does reduce your risk of death by 24%. And I think I'd take that.
Yeah, absolutely. And I think with these sorts of conditions, any treatment that gives you a 1 in 5 chance, theoretically, of a prolonged response is going to be a huge difference compared to the dark old days of chemotherapy alone.
Right, exactly. And then the next generation will add 10%. So rather than it being 25, it'll be 35. And you're just like, okay, we are going to get somewhere. It will just take time.
Yeah, absolutely. And these things, the biliary tract cancers are among the hardest to treat, as we've said. And we just need to find that switch. But we're continuing our trip
Journey.
into the hepatobiliary center with the hepato section of that title. We'll be talking about. I'm just so good. I'm just so good at this. And we'll be talking about hepatocellular carcinomas, another area where, there hasn't been a whole lot. We did talk about one of the studies, Emerald 3, in the early phase management of hepatocellular carcinoma in our ASCO series. So if you're at all interested, go back and listen to those episodes. They're long, but they are worth it. And until then, I just got to prepare people. I've got to prepare people for what they're signing up for.
That's it.
But we will hopefully see you all next week for more Oncology for the Inquisitive Mind.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.